Welcome back to Mic'd Up with ChiroUp. We've got Tim and Brandon for the podcast today, where evidence is going to meet real-world practice. Today, we're going to kick off a conversation that may not completely change how you treat, but it is going to change who you treat and when you choose to treat them. This distinction alone can have a huge impact on your outcomes, especially when you're caring for young and active patients. So what we are going to cover is we're going to dive into extracorporeal shockwave therapy. We're going to explore how. We're going to explore when, and when applied correctly, it can shorten healing times. It can support an earlier, safer return to play for these young athletes with apophyseal injuries. So we're going to provide you some real new research as an alternative to the traditional wait-and-see approach.
But before we dive in, we'd love it if you'd take a second to hit the follow button. It's one click that'll go a long way in helping us expand this reach of the world's best evidence-based chiropractic practice podcast. Might not be true, but we're going to run with it. So what would you like to start with, Brandon?
This is going to be, so before we dive into the shockwave therapy, I want to cover a section that was actually brought to my attention by a subscriber. So I was in Ohio for one of their state associations, and Richard Mason, who is a long-term subscriber, and I'm not going to say a critic, he's probably listening to this right now. However, someone who just constantly gives us feedback. Hey, I read this blog, you should consider this. Or what do you think about this new technology? And what he brought to my attention was really the ongoing discussion about strokes. Now, what he was not trying to do, and what we're not going to do, is to inflame the debate. However, what he provided me was a paper that is going to hopefully sharpen my clinical awareness, and then we're going to dive into some realms around that we can provide some more information on to help us treat or determine who not to treat when it comes to these cases, because there are a few practical questions. And there are some meaningful ways that we as chiropractors can evaluate patients presenting with, which is what they almost always present with, headaches, neck pain, and dizziness. And these patients deserve a better evaluation. So these patients, we're going to give them a little bit more of an evaluation and use some clinical decision making and ultimately provide them with better outcomes.
Yeah, fortunately, the old theory that spinal manipulation, neck adjustments cause stroke is out the door. That there have been 7 major papers in the past several years that have shown that's not true. While there is a correlation, there's not causation. Yes, people who have spinal manipulation go on to have strokes, but at no higher rate than if they saw their PCP, meaning that spinal manipulation was an innocent bystander on the process of someone having a stroke. That means that we as chiropractors have a role, that we're not causing strokes, but we also need to make sure that we're identifying them. We are safeguarding that patient's health by recognizing those early warning signs of some serious event like a stroke. So our ability to do that is what's going to make the difference in that patient's lives. We have a responsibility to identify those risks before we begin treatment. And that starts with really listening to the patient. We need to get a structured clinical history. We can detect those red flags that are associated with CAD or with VBAI and make informed evidence-based decisions about what to do with this patient. We're protecting patients. We're reinforcing our profession's commitment to being true diagnosticians in excellence and patient safety.
What's so interesting is, Tim can do a 12-hour class on lower back. He can never look at his notes. He just, looks at information. He starts, spewing out all this clinical gold. However, he did write down that sentence.
I'm glad you used gold.
because really that is a very defining sentence. And what he just discussed is that there is no correlation. Causation to make that known. Now, with that being said, let's not go down that rabbit hole. That rabbit hole, not that it's over. There's always going to be questions on that. Let's talk about something that we can control, which is that Chiabi paper that Dr. Mason was so generous to say with me. This was a 2019 paper, Annals of Medicine, not Internal Medicine. But instead of reading the entire paper and going back and finding that, we would like to present to you a 5-question screen that you can use for patients that are presenting with neck pain, with headaches and dizziness that can signal a vascular event, and kind of go over what questions are we going to ask them and what does that really mean. And so the first question is going to be about onset and triggers, because most of your musculoskeletal complaints are going to present differently than a vascular complaint. So asking the patient, how did the pain begin? Was there any recent trauma, fall, sudden neck movements, illness, heavy lifting, coughing, dizziness, vertigo, nausea, vomiting, gets you in the ballpark of, was there something that triggered this, or is this progressively getting worse, or have they had this before? The next is going to be pain pattern. This is going to be I think, one of the biggest triggers, when it not necessarily has to do just with the vascular event, but is this person suited to be in my office? Because if the pain is continuous and consistent, or does it come and go? Now, this is a big piece, because a continuous neck pain or headache without relief should raise suspicion, just like continuous, symptoms in the stomach should raise, suspicion. Mechanical pains are when you move, it should hurt. Chemical pains or vascular pains or systemic issues, they're there until you fix it. So we can fix mechanical problems with mechanical solutions. We should go after chemical problems with chemical solutions.
Yeah, you said one thing a few years ago that was profound, probably only one thing, but you had said that...
Did you write that one down?
I did. When you talk to patients, you say, when you move, can you make it hurt? Because my treatment depends on movement. And if you can't move and make it hurt, if it doesn't change, if it doesn't get better or worse when you do that, then there's less likelihood that I'm going to be able to help you. The third question that we're going to ask with regard to this is the timing. When did it start? Has it been continuous? We don't like that continuous, unrelenting discomfort, even if it's mild, all the way up to severe. If it's just there and doesn't stick, not so good, especially CAD pain. It's usually persistent and atypical. And that means also it's persistent even if you do number 4, take some medication. So what's been your response to medication? If it feels better, then it's less likely that it's going to be a CAD issue, more likely musculoskeletal. If it doesn't change, if it's unresponsive to anti-inflammatories and analgesics, not quite as good. And number 5 is the laterality. Is the pain on one side of your head, or is it on both sides of your head? That bilateral, not quite as concerning. Unilateral, maybe a little more. We know that migraines are often unilateral, but so are bad things like strokes. Now, a quick refresher here, a couple of different kinds of strokes. There's a hemorrhagic stroke. That's less common, fortunately. About 15% of all strokes are hemorrhagic. That means the hose has burst. That's a bad thing. Obviously, it's much more deadly. Most of that pain is severe. You can imagine if the hose is getting ready to burst, it probably hurts. And it's going to hurt unilaterally, usually on the side that it's bursting. The other type of stroke is an ischemic stroke, where something's gotten plugged up. That's 85%, not as deadly, but certainly not good. It's usually not as severe of a headache, but it's not unusual to have one. It's usually unilateral, and it's usually on the same side where that vessel is getting plugged up. And that vessel is getting plugged up by one of two things. Either number 1, a thrombus, which means a local clot, or number 2, an embolus, which means a clot on vacation. It's traveling somewhere. Now, a cervical artery dissection is different. That's not a stroke. It's a precursor to a stroke and an ischemic stroke. What that means is that the arterial walls are separating. It's allowing blood in there. It's forming this intramural hematoma, a blood clot, which then, of course, narrows the vessel, or the clot could break free and turn into a thrombus. And that usually is going to be a unilateral neck or head pain. It's going to be something typically that feels different, and it's persistent. It's something that we have to screen out, because most of the time those vessels that tear with a CAD are going to have some underlying vulnerability. So we'll ask about that in our history.
Yeah, you brought up a really good point about the unilateral part and it being similar to a migraine. And that's part of one of the talks that we do. And with a migraine, the things to remember is that it's often common, meaning a migraine is characteristic. Once they've had one migraine, they tend to keep on having the same type of migraine. It can be different for all different people, but that person experienced the same kind of triggers or same kind of aura. It's slowly developing as compared to something like a stroke, which could be due to a traumatic event or what have you. And the last piece is the bilateral headache. It's just, let's just call it less characteristic of a stroke. It's more commonly associated with a primary headache disorder like what you and I see, a tension type headache or a migraine. Although, just like anything else, exceptions can always exist. But really, at the end of the day, we can take these questions, we can deliver them and get the answers in a minute. And 100% honesty, I use voice to chart for all this. I don't write anything down anymore. I don't type anything. I have a conversation with the patient. It's going to, for one, significantly sharpen my clinical judgment, but it's also going to determine how I'm going to proceed with care with that patient. And if you feel like there's something awry, there's something that doesn't check all the boxes, that's when you're going to use a CTA or an MRA as a first-line modality for any kind of rapid detection of a vascular event. Now, just to kind of review, Tim, what are the signs and symptoms that you're going to be looking for before jumping into, significant imaging?
Were you not paying attention? We just went over these. Something that's sudden and persistent, it's unrelieved by medications, and it's unusual, whether that be neck pain or headache. We're also concerned anytime there's some vertigo, and certainly if there are neurologic symptoms, most often numbness or weakness. But it could be other things like changes in vision or difficulty speaking, difficulty swallowing. Certainly, when somebody's having a stroke, oftentimes those symptoms aren't just an isolated occurrence. They don't have just neck pain or just vertigo. They have this constellation, and that's really concerning. When we look at the historical factors, we said, did they have trauma, even if it's a minor trauma? Does this patient have a connective tissue disorder? Do they have vascular risk factors? One of the more recent thoughts is infections. And I think that there's something to be learned here. I know that James Demetrius, who helped us with our webinar, which I'll mention in just a minute. I guess I already did.
You did,
yeah, thanks. James talked about how fluoroquinolones have a detrimental effect to connective tissue. We know that they're very much related to tendon ruptures, that if somebody has an Achilles tendon rupture, if you take an antibiotic, you're more likely. In fact, the antibiotics oftentimes tell your doctor if you start to have tendon pain. It's because it's weakening connective tissue, and we can't forget that these arteries are connective tissue. So we might find that it's not the infection, maybe it was the treatment of that infection, but either way, an infection's a risk factor. And then certainly our careful clinical exam. We're going to do a neurologic exam, we're going to look at the cranial nerves, and we're going to look at things, the same thing that a policeman would look at for somebody who's drunk. What's happening to their cerebellum? Can they do a normal finger to nose? When they hold their arms out in front of them and close their eyes, is there any drift of their hands? If you rotate your head over the top, we're not doing George's maneuver, but that could provoke a drift in the hands as well. And one of the things that Tom Mashad brought up in our webinar is he does a quick walk and turnaround test. He has somebody walk down his hall several steps, abruptly turn around and come right back at him. And you can imagine what someone would do if they were drunk, i.e. a cerebellar impairment. They're going to stumble. It's not going to look very graceful. So doing those simple sorts of tests as part of a comprehensive exam makes a big difference. If you want to dive into all of those, our most popular webinar of all time was with James Demetrius, Tom Mashad, and some other guy, I forget his name, and that was Brandon, who narrated the entire process.
It's really funny because I told someone in a seminar, it's our webinar, like ChiroUp's webinar, and I got an email back, I'm like, it really wasn't you guys.
Yeah, these were the smart kids, and they produced a great webinar as far as what are the clinical findings that we're looking for, what's the history, and also what's the data behind strokes showing that there is not a significant, there is no causation in spite of there being a correlation. If you dive into ChiroUp, into the forms library and search safety of neck manipulation, you'll see all of those 7 studies. It's a great tool that you can use reactively anytime that you need to combat misinformation.
So we're done with that connective tissue. Let's dive in something maybe we could not be treating. That's not fun, right? It's always fun when you can treat a patient, not decide when not to treat a patient. So for today's clinical commentary, we're going to build off a topic that first took shape in a recent blog that I wrote. It was back in, I guess it would have been December of 2025, and it took on a life of its own. So we get feedback all the time. However, once this blog released, I started to see a trend in a misinterpretation of the blog, and I want to focus on that and then open it up to some more research and why the trends in shockwave therapy are changing. And I think it comes down to an understanding and how we apply treatments to growth plates versus apophysis. I think that one of the things that I talked about was when not to use shockwave therapy, and there's 4 things in there. And if you want to take a look into that, go to the resources tab on ChiroUp, and you can see all of our blogs, all of our podcasts, and that kind of stuff. However, during that blog, as always, I asked a question: is that if you have any other research to back up a different claim, please let me know. And our community, as it always does, as let's call it a real world sounding board for chiropractic curiosity, I got tons of responses. Mike Urban and Michael Krasnoff. In fact, Michael Krasnoff sent me a bunch of articles, and he said, hey, we can actually be using shockwave therapy for multiple things, which, of course, he was exactly right. And I want to cover those today because I often think about this. I often, question myself, is that what can I actually use shockwave for 100% transparent clarity and why I care is, 1, to get patients well, but 2, we got a shockwave unit. Let's figure out how we can help patients better, and then also not use it for other kind of applications, but what can we use it for? I mean, I think it works for multiple things. I know Tim uses it a lot of times for off-label uses. I'm not sure what he's doing. However, is it something we can use? Should it be helpful, or are there certain things that can be harmful for? And I think that's where we want to cover in today's blog. So let's talk about growth-related injuries, because most people think about a growth plate and apophysis as the exact same thing, and traditionally this has been listed as a contraindication for shockwave. And myself, and I think I can speak for Tim, we're not going to take a hard stance against its use or for its use, but let's give you some evidence. Let's give you some real world information and how we can use this information to write better blogs, better podcasts, and then, of course, use this information to debunk long-held assumptions and to make sure we use it for the right kind of situations for, in this case, the treatment for apophyseal type injuries in young athletes.
Yeah, so when those bony spots get overwhelmed, whether it be a growth plate or an apophysis, it just means that some stressor is occurring, and much like a stress fracture, if you continue that stress, if the stress exceeds the body's ability to heal, there's going to be a problem. And this could be a minor traction apophysitis like an Osgood-Schlatter's or a Seaver's, all the way up to a more serious physeal fracture where the force has taken the path of least resistance. It's like a piece of paper that you've started to tear and it goes, and now we have a significant problem through the growth plate. Often these injuries, both of them, will behave themselves as long as the patient rests and you rehab it and you have some smart load management. But when that starts to become chronic, that's when you can turn a simple condition into something that's a lingering clinical puzzle, both for you as well as the patient, because they're trying to get back to their activity. We know that little Johnny has the Firecracker 500 and can't miss that tournament. So for us, working with young athletes, understanding how these tissues function is crucial. How they function, how they fail, and how they heal. The first thing I think is understanding the difference between a growth plate and an apophysis. That a growth plate, or the physis, this is at the end of a long bone, and it makes the bone longer. Think of that black snake from 4th of July that you light and it grows. That's what it does. It makes the bone longer. That growth plate is made of hyaline cartilage, and it's going to resist compression forces, because that's what bones do, and resist shear. It has a hypertrophic zone in it. So this is not just plain hyaline cartilage, but it has a zone that's actually going to proliferate, like that snake. Whereas an apophysis, this is a bump on the bone where a tendon or a ligament attaches, and it's not made of hyaline cartilage, it's made of fibrocartilage. And its role is not to resist compression, its role is to be able to handle tension and traction. It's where a big thing like an Achilles or a quadricep is inserting, and it's going to be pulling on it, especially when those athletes start to get a little bit more muscular, and now we've got massive forces pulling on a piece of cartilage.
Tim, just to clarify, because this is kind of a confusing topic, and, from school to boards 15, 20 years ago, or maybe 30 or 40 years ago for you, let's define growth plate, because specifically for this conversation, we're talking about the physis of a long bone. While the apophysis technically contains growth cartilage, it's sometimes loosely called a growth plate. So it creates this, confusion when we talk about a growth plate. The apophysis is a secondary ossification center and behaves just very differently biomechanically and really histologically. So for the following conversation, growth plate means physis and apophysis is being considered separately. Really, this is the bump where tendons and ligaments attach. It's so interesting when you look at pitching-related injuries, or really even any kind of sports-related injury. What we're finding from the research is not necessarily the activity that's causing the problem, it's the ability to heal. And that's an important aspect to understand, is that what we're looking for with these apophyseal injuries is little Johnny in the Firecracker 500 or whatever the event was, isn't giving himself enough time to heal. So how can we speed that healing up? So the articles that we're going to talk about have already been submitted to our research team. Just so everyone's aware, all the research we put into these podcasts and blogs and everything on PubMed goes through a team of researchers. That's where you're going to find in the research review section. And then those things that are pertinent to your practice and my practice, or your social media feed or my social media feed, goes into the section. And that's how we can actually distribute that throughout the entire program. However, these I kind of went into deeper in these articles to figure out how are they actually applying shockwave therapy. And it was interesting because what they started to do with these patients is they did very light, right around 1 bar, very low energy settings, 1,100, 2,000 shocks.
And we're talking about apophyseal injuries here, not growth plates.
Yeah, absolutely. Because that's probably the biggest piece of this, is that those things are very close to each other when it comes to little kids. So I was curious on how they're doing this, and to make sure nothing else was causing the pain relief, because what's being done before and after the shockwave therapy treatments. And one thing they did include is there's no anesthesia also provided, so it couldn't have been from some other kind of medication induced pain relief. But what they did is they found through clinical palpation the point of maximal tenderness, which is usually right over the apophysis and the surrounding tissue. However, they don't put bold in research articles. However, strict avoidance of the active growth plate. So what they did with the applicator is they angled it downward and medial and lateral, depending on the position of the growth plate, and they would keep it on both sides of the apophysis, and they all made notation of keeping the epiphysis outside the shockwave field. So something you want to consider, for people using radial waves, you're not going to get quite as deep, but for people using focus shockwave, really want to make sure that you're positioning that wand appropriately, the applicator. For Osgood Slaughter, they stayed 1 to 2 centimeters away from the tibial growth plate, and for Sievers 3 centimeters away from the calcaneal growth plate, and then once again just going side to side. They also made sure that after shockwave they gave the person a temporary period of activity restriction. They used bracing if needed to let that tissue start to heal. I like to think of shockwave as restarting biology. You're using mechanotransduction to stimulate those cells, and as we know, that those kinds of cells, those kind of cartilage, respond to stress. They can release the appropriate growth factors. They can bring blood flow to the area. And then, of course, with all these patients, they brought them back to sport slowly. And then they also use manual therapy, manipulation, and any kind of footwear modification, especially in Sievers disease. So the takeaway message for me is that what I want to do with my patients who I need to heal faster because they've been doing too much, because they have parents who don't let them heal, which I fit in that category also. However, start with low energy focus shockwave, put it around the apophyseal injury, slowly increase the bar, increase the load, increase the energy you're putting into that system, and then do the same things you should be doing for all these conditions. Incorporate proper load management, incorporate the right kind of management, and don't do the typical wait and see. Oh, you've got Sievers, take 2 weeks off and let's try it again. That's just not going to work, and we're done with that mentality. Let's see if we can get these patients not only back to the field faster, but also correct the functional imbalances that created the problem in the first place.
Yeah, and this is kind of a shift in thought process that years ago we thought that using a shockwave anywhere near a bony prominence in a developing person or a growth plate was a hard stop. Well, it still is for a growth plate. And most of that research had come from the authoritative journal in musculoskeletal care, the Journal of Urology.
That was that off-label use I was talking about.
I'm starting to see a connection here. That's how Shockwave got into Journal of Urology in 1989. And it said, don't do Shockwave anywhere near those types of things. And it was contraindicated at that point in time. But then that started to soften, terrible analogy, through the years. And
Pun intended.
And the Shockwave thought process was that there really are no harmful histologic changes when we're doing this. And so the research has changed from saying when it comes to an apophysis being a hard stop, like it still is for a growth plate, the apophysis, it's shifting, saying, maybe we could try this. It's not never do this, and it's not always do this, but there's a lot of evidence to say use your expert clinical judgment and determine if it's appropriate. And there are some parameters that we'll talk about as far as applying that safely and cautiously. But there's definitely been a shift of mindset. The growth plates still off limits. The apophysis are probably on limits and probably helpful.
Yeah, absolutely. And I think that one of the things that the chiropractic profession does so well is listen to the research, but still practice, still experiment, still stay curious, because we can see very clearly that before 2015, all the research, all the use was really going more towards overseas. And as soon as we start...
That's where growth plates were invented.
Exactly. Yeah. Well, yeah, anatomy hasn't changed. It's not different in Europe as compared to the United States. However, FDA approval does. And in early 2000s, we started to see that we're getting approval for chronic plantar fasciitis and starting to use radial shockwave systems and focus shockwave systems. So really, the regulatory bodies kind of open the amount of things that we can really use. However, this is something as a mainstream tool that we can use for musculoskeletal care. Now, I have no affiliations with any companies. We did our research as far as selecting one. However, this is something that, for you and your practice, you have to see if it fits with the kind of practice you do. And if you don't, you don't. However, speaking on a personal level, the first month that we have it, I just started experimenting with different people. And we did, fortunately, have two interns, a preceptor and a new doc, who had previously used it in their last clinics. However, we tried it on everything, and we're seeing really good results. But the one thing I do want to, as a take-home point, is that we don't treat Shockwave as one thing. It's not, we're going to do Shockwave for 9 visits over 3 weeks. We do Shockwave in conjunction with whatever else that patient needs, with functional evaluation, with manual therapy, with directional therapy exercise, whatever that patient may need. We're not going to change everything and just supplement with just this one technique. It's a part of a recipe for certain conditions. And based on this podcast and based on our research, we're adding to the conditions we can treat to include growth plate injuries.
Yeah, so as far as the take-home points that I'm getting from this is that recognizing the difference between a growth plate injury and an apophyseal injury, it's not the same. Apophyseal injuries are Osgood-Schlatter's and Seaver's and Little League elbow. Those are traction-based injuries. They're not growth plate fractures, and differentiating them is really going to be crucial because one, we could consider using Shockwave, the other one, we don't want to do that. Shockwave is also about where you treat, and not whether you treat, but where you're going to focus that energy. That radial shockwave applied over an apophysis an apophysis and the surrounding soft tissues, and avoiding the growth plate is the right place to put that. And then finally, the parameters and the context of that therapy definitely matter. That we want to make sure that we're pairing Shockwave with the things that you talked about, that we're modifying their activity so the stressors are diminished, giving them bracing if need be, getting proper rehab, and getting them on a graded return to sport process. And also the parameters of that Shockwave, making sure that we're starting at the lower end of the spectrum, usually in the 1 to 3 bar range. All the studies that have supported Shockwave therapy for these apophyseal injuries have started in the lower range. And also realizing that things change. One thing that we dismissed in the past was the ability to use Shockwave over an apophyseal injury. And over time, we find out that could be supported by the research. It's like anything else. When something says that it's not supported by the research, it doesn't mean that it doesn't work. It just means there's not research to support it. And chiropractic has come a long way in many of the things that we address to show that what we're doing is supportive. It's a matter of brave people taking calculated chances through expert level opinions and expert level intuition and doing things and then monitoring that carefully. And that's where Shockwave fits right now. It's in that evidence-informed state saying, as far as apophyseal injuries, in the evidence-informed state, saying this is something that may have benefit. And it's looking very promising.
Yeah, absolutely. And really, for our clinic also, we've seen patients who have, the number one thing has really been, at least for me, gluteal tendinopathy, and kind of breaking through that plateaued version that they're getting better, but not getting back to 100%. We've been, for lack of better words, shocking the system, and starting to see them overcome that plateau. Now, to round out the podcast here, let's go over one fun thing in the EHR: two-way texting. To start that off, I'm going to have Dr. Berlesman review with you the legal bills that we have incurred just having two-way texting a part of the EHR. How fun has that been?
I'm going to vomit real quick.
Apparently, the ability to communicate with patients is a big deal. So that was one of the biggest hangups. And really, everything we do here has to be 100% compliant and secure. So now that is done, and Dr. Berlesman has a few more gray hairs, the two-way texting is out. We have 3 clinics using it, 2 more in beta right now. And realistically, if you can use an iPhone, you can use our two-way texting. It has pretty much the same UI. We did something kind of unique, though, and I think this is something that builds on the kind of our mission as a company, is that we're not looking to nickel and dime people. So what we did is, instead of just saying, hey, all texts going in and out are on you now, we're still going to include the transactional text messages, because your appointment reminders, your Google review reminders, if they cancel an appointment, those kind of things, we already include that in the service of the EHR, so we're not going to charge you for those things. However, now you have the ability for your patients to respond back to those appointment reminders. It really is going to save you time, really probably save your staff the most time, and it's going to make it easier on your patients to communicate with you. And as always, if you need more than two-way texting and appointment reminders and customization of text, all the things that we offer, we still have an integration with Aloha that can do everything else, just making sure that we have a service that can conform to any of the needs that a chiropractor may have.
Yeah, it's one of those. I think there have been 2 things in the past year that now I really couldn't live without, and didn't expect one of them. The first one is the voice to chart that we just...
Blood pressure medication?
Yes, that too, after the legal bills. The first one is the voice to chart. Patient walks in the room, I hit the button, it records it, and takes my subjective component. I thought I would not be able to live without that, and I was pleasantly correct on that one. The second one was two-way texting, that I know there were a lot of services out there that did that, and I thought, it's a nice option, it's not crucial. But now that we're using it, you wonder, how did you ever practice without two-way texting? It'd be kind of like having no texting on your phone. If you want to communicate with your family and friends, you're going to do it by text 9 times out of 10. It's easier, it's quicker, it's contemporaneous, and it's invaluable in practice as well. So it's been a huge boost to our practice.
And thank you to our coder and developer. He always likes it when we call him out, Jeremy. He found a way to do this at half the cost of any other service. So it's been kind of a fun, exciting journey to make sure that we can provide a service that's not only going to be helpful, but also going to save our subscribers money in the long run. As always, to close us out, really appreciate you listening to the entire article. We got to cover a little bit on vertigo, a little bit on dissections, and then really take a deeper dive and more of a discussion on the uses of shockwave therapy, what it can be used for, what it cannot be used for. And as always, everything that we talk about is well-researched, well-vetted, but it can all change. That's the beauty of doing what we do. The research is going to continue to change. Hopefully we can stay on top of it and deliver that information to you, and it's useful to you in your practice and more importantly, your patients.